Hi guys, welcome to this class, and in this very video we are going to be talking about polycythemia. So without wasting much of our time, let's get started. Yeah, welcome back. Now, talking about polycythemia. 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 Now, what is the meaning of that? As usual, if we are to divide these, you see the word poly that we have here, it means numerous, or many. So now the word cyte that you have here, it means cell, and what emia right here means the blood, and to be specific, it is the red blood, so the red blood cell. So when they say polycythemia means numerous or several or many red blood cell. So the point is, when there is an increase in the what? In the level of red blood cell within the bloodstream, that is what we call polycythemia. As simple as that. Now, for you to understand this very well, remember, we just finished talking about the red blood cells, their origin, production, their lifespan, their function, and most importantly, we just finished talking about the anemia. Now, the point about anemia is that anemia is actually a reduction in what? In either the quality or the quantity of red blood cell. Which means, if anemia is what? If anemia is a reduction, in the what? In the quantity of red blood cell, then polycythemia is an what? Is an increase now, and not a reduction. And that is telling you that anemia and polycythemia are what? They are opposites. They are what? They are opposites. So when there is not enough red blood cell, we call it anemia. But when there is an exaggeratingly high level of what? Of red blood cell, we call that what? Polycythemia. Now, the next thing we should understand is actually the types of what? Of polycythemia. But the point is, the type, it gets confusing. But the best way to understand the types is to actually talk about the causes of what? Of polycythemia. What can happen to someone? What can happen to a human being for that person to develop what? To develop polycythemia. What can trigger what? Polycythemia. What do you think can cause increase in the amount of what? Of red blood cell that a what? That a red bone marrow is popping up, is popping out, is knocking off. What can cause an increase in what? In the red blood cells within the body. So to understand that, I would like to rub the board, come in with the mechanism, and talk about the etiology. So, I'll be right back. You're welcome back. Now, talking about the etiology of polycythemia, we should better start from the physiology of production of the red blood cell. Now, you already know what it is. The point is that whenever there is a reduction in what? In oxygen level, you know that there's going to be transmission of impulse to the where now? To mainly two organs. So the first one is the kidney. And the second one is the liver. Now the point is that both the kidney and the liver, when impulses are sent to them, we have some cells within them that are going to release something. And that thing is called erythropoietin. Erythropoietin. And after that, erythropoietin, it will go act on what? On something right here. So let's assume this is a bone. So the erythropoietin will act now. It will act. So let's take it this way. It will act on the bone cell. So not the bone cell actually, but it's sent within the bone marrow. And we already know that is what? Hemocytoblast. Cool. Now, hemocytoblast is going to develop through a series of stages. And then, so it's going to develop to become things, lots of cells, until it forms the final one here, which is the reticulocyte. Reticulocyte. And reticulocyte now will find its way into the what? Into the bloodstream. So it's going to find its way into the what? Into the bloodstream. So reticulocyte is going to move straight up into the what? Into the bloodstream. And within the bloodstream, after like 2 to 3 days, it's transformed to become the what? The proper red blood cell. So the red blood cell itself. So the RBC, the red blood cell. So this is just the what? The production of what? Of red blood cell, which we call erythropoiesis. Now, with these established, remember, what are we trying to do? We're trying to talk about the increase in the production of what? In the production of this red blood cell. So what do you think can happen that is going to aggravate this process, that is going to promote this process, that is going to hyperstimulate or overstimulate this process? What do you think can happen to make us have a lot of what? A lot of red blood cell inside the bloodstream? Now, we can always start with the what? With the stimuli right here, which is reduction in what? Reduction in oxygen level. Now, remember, we said, if you are taking in oxygen from the environment, passes through the what? The airways and down into the what? Into the lungs. So down into the what? Into the lungs. Now, the point is that if oxygen is coming in and straight up staying into this person's lungs, what is going to take this oxygen away from the lung? What is responsible for taking away the oxygen from the lung? It's actually the blood capillaries that are coming from the heart. These blood capillaries, they contain what? They contain blood within them. And we have a vehicle of the blood. You've known that from a very long time. And that vehicle of the blood is called the what? The red blood cell. Red blood what? The red blood cell. They are going to take up this oxygen. So the first person oxygen gets in contact with after leaving the lungs is the red blood cell. The red blood cell will pack them up. And now they will start moving the oxygen straight up now. So we are now taking them to somewhere new. And the question is, where is that? They are bringing them down into that mighty organ, an important organ of the body. So we name it already. So, and that is the heart. So let's make it a little bit special because we're needing some certain things. I'd like to make it bigger actually, because we are going to need some certain things. Let me know that. So I just want to draw it all over again. I want to make it better because we have some things that you have to see very well. So the point is, or can we just do this? Should we bring it down there? And then the diagram will come down across this place. Beautiful. Let's do that, guys. You see, this oxygen now, they find their way into this place. So let's bring our heart right here. So, heart. Excuse me. Oh. Open for a very long time. Let me just swap for black. So, yeah. So guys, what I'm trying to drive at is that when you breathe in oxygen, the oxygen is going to be carried by the red blood cells. And the red blood cells, they are going to bring you straight up back into the heart. But which part of the heart? We all know that the oxygenated blood, it comes back into the what? Into the left excuse me guys. So we want that oxygenated blood will enter back into the what now? We enter back into the left atrium of the heart. So oxygenated what? Oxygenated blood. Now the point is that the oxygenated blood is going to be pumped out into this what? Into the aorta. And the aorta will bring it down. So, and it supplies different what? Different body organs. Now the point is, imagine that this person has a kind of disease condition. And that disease condition is restricting the amount of oxygen coming in. So if there is a kind of inflammation, instead of what? Of the size of the trachea or the airway generally to be patent like this, nothing inside it, it turns out to become something like this. So what do you think will happen to the amount of oxygen getting into the lungs? The amount of the oxygen getting into the lungs is going to reduce. And now, which kind of condition can actually cause this kind of thing? The most popular one that we know is COPD. C what? COPD. It is called chronic obstructive pulmonary disorder. As simple as that. So if someone has chronic obstructive pulmonary disorder, there's going to be a reduction in the amount of oxygen getting into the lungs. And when there is a reduction in the amount of oxygen getting into the lungs, it means the red blood cell now, they won't be really taking a lot of oxygen. They won't be taking it back to the what? Back to the left atrium. So if there is a reduction in the amount of what? In the amount of oxygen getting into the what? Getting into the left atrium and the left ventricle, the amount of oxygen moving in the aorta is going to be what? Is going to be low as well. And because of that, when blood reaches things like the kidney, right here, or things like the liver, the cells inside them, they are going to release what? They are going to release erythropoietin. Because what they sense from this blood is what? A reduction in oxygen level. A reduction in what? In oxygen level. And they are going to release what now? Erythropoietin. Now, before we proceed, normally, let's assume that the amount of what? Of red blood cell inside the blood is like, let's say 45%, which is normal. And the point is, let's just use percentage. Let's use some certain numbers to make it easy. Let's say we have 100 RBCs inside the human body normally. The point now is, with the fact that oxygen is not getting to the bloodstream, the red blood cells, they are completed. They're supposed to be 100 and they are 100. But the point is, oxygen is not getting in. And the lack of oxygen is sending impulse to the kidney and the what? And the liver. And because of this, they keep producing what? Erythropoietin. And erythropoietin will do what? Erythropoietin will stimulate the production of what? Of red blood cell. By what? By acting on the cytoblasts. And that is going to aggravate, it is going to increase the what? The production of what? Of reticulocytes within the bloodstream. And after that, it's going to increase the what? The number of what? Of red blood cell. For example now, let's say after a single production, another 100 is going to be produced normal. So the point is now, there's another 100 now being born into the bloodstream. Which means right now, the person has like 200 inside the bloodstream. But guys, because all this mechanism occurs all over again, due to this disease condition, does that alleviate the problem initially? As in the initial problem? No. The initial problem is that there is a reduction in the amount of oxygen getting into the lungs. So the point is, even after we have 200 red blood cells within the bloodstream, the point is that there is still going to be a reduction in the amount of oxygen within the lungs. And due to that reduction, another impulse is still going to be sent back to the what? To the kidney. Kidney will still produce again another what? Erythropoietin. When another erythropoietin is being produced, the same process keeping happening all over again. And there's always going to be an increase in what? Increase in the red blood cell. And tell me, we said increase in the amount of red blood cells in the bloodstream. It's called what? Polycythemia. Simple. So, polycythemia aggravated. Polycythemia. As simple as that. So, the point is, if someone has a chronic disorder of the lungs that is restricting the movement of oxygen into the lungs, that can actually be a cause of what? Polycythemia. Because fake impulses will already sent to produce erythropoietin and to trigger the total amount of what? Of red blood cells within the bloodstream. As simple as that. Now, after that, what else can you think of? Imagine This is just the disorder of the lungs, right? Now, imagine that we have a disorder affecting the heart. An example of that disorder is actually a hole in the heart. That is what you know it as, or what majority know it as. Normally, they are congenital disorders, and normally you can call them TOF. So, TOF. I think I have to change this marker or change the ink board instead. When you say TOF, TOF means tetralogy of Fallot. Tetralogy of Fallot. Tetralogy of what? Of Fallot. So, if we are lucky, one of these days, we'll take it up. It's actually a pretty simple condition. When you hear tetra, tetra means 4. So it means this disease condition called TOF is characterized by 4 main manifestations. But you are only interested in just, let me say 1. Forget about the rest. We are interested in what really happens in tetralogy of Fallot. Is this first thing you are looking at? There is a hole in the in the septum of the ventricle. So they call it VSD, ventricular septal defect. So I don't want to go deeper into that. The point is, there's a kind of defect on the septum of the ventricle, and the defect is a hole, as simple as that. So that is what we know generally. You say hole in the heart, yes, hole in the heart. So the second thing that used to happen is that, you see, right on this place, instead of the aorta being at this end, the aorta is attached to this end. So those two things are what we need here. So the aorta instead is around this place. The aorta is just around this place. So, and it continues downward like that. That is what we need. Forget the other ones. The other ones, if I haven't forgotten, is there's going to be a thickness of the what? Of the ventricular wall. So, and that is because of the amount of work it's doing, pushing blood. The point is, the last thing is around here. You see, mainly the right part is what is affected mostly. So, not to get you confused, you do not have to take note of this. I'm just saying it if you are interested. So the point is that in tetralogy of Fallot, the person has hole in the heart. So you call that ventricular septal defect. So VSD, ventricular septal defect. Ventricular septal defect. The meaning of that is the ventricle, its septum, that is the septum of the ventricle, has been affected. It has a defect. So, and the defect is hole. So there's a connection between the right ventricle and the left ventricle. And the second thing is what we call overriding of the aorta. Overriding of the aorta. That is the second thing in tetralogy of Fallot. Overriding aorta. So the meaning is that the aorta is going to do what? It's going to be found directly on the what? On the ventricular septal defect, on that hole. Now, what is it going to cause? You'll understand later. So another thing that will happen is called pulmonary stenosis. Pulmonary what? Stenosis. I want to change this marker. I've said it before. Apologies, guys. I'll deal with it very soon. So, stenosis. So, what is pulmonary stenosis? You already know stenosis means hardening or constriction. Or something to get hard and constricted. So, constriction and hardening of the what? And hardening of the pulmonary valve. Pulmonary what? Pulmonary valve. That is what pulmonary stenosis means. So, it is the constriction and hardening of the pulmonary valve. Now, ask yourself, right here, the pulmonary valve normally is meant to take the blood. So, to do what? Pulmonary artery. And pulmonary artery is meant to do what now? To take the blood to the lungs. So, to collect what? To bring in oxygen back to the heart. So, this guy is taking what? He's taking the oxygenated blood normally to where? To the lungs. To bring backwards, to bring back oxygen down here. So, the point is, you have a valve here, a gate. The gate is usually open, as in, it is meant to open up for blood to flow upward like this. I know you know that before. But in pulmonary stenosis, this gate, this valve, it gets closed and constricted, it becomes hard. So blood is unable to go to the lungs, in this case. I will explain the relationship between all these things and what? And polycythemia very soon. Now, one more thing is that the ventricle, this right ventricle, is become hypertrophied. So ventricular hypertrophy. So ventricular hypertrophy. Ventricular what? Hypertrophy. Now I'll explain everything so you understand. I don't have an intention of going deep into this, but I've written it. I'm going to explain everything. But let me quickly change the marker, as in the ink board for this blue marker quickly. I'll be right back. Yeah, apologies guys. Now back to work. The point I'm trying to make here, let's go over all these things one more time. We said, what can lead to the increase in production of red blood cells? So we picked a patient suffering from COPD, which is chronic obstructive pulmonary disorder. That itself is a combination of two things, chronic bronchitis and emphysema, down on the side. So the point is that in COPD, there's a reduction in the amount of oxygen getting into the what? Into the lungs. And because of that, tissue hypoxia will set in. And reduction in oxygen is going to be picked up by what? It's going to be sensed by what? By the kidney cells and the liver cells. In response, they will release erythropoietin, and that triggers the hemocytoblasts to what? To cause the production of what? Of red blood cells. And that is going to cause what? Polycythemia. Now, apart from that, we said if someone is suffering from tetralogy of Fallot, we said tetra means 4, which means 4 big clinical manifestations are occurring here. And what they do is that, firstly, they cause a ventricular septal defect. The meaning of ventricular septal defect is just a hole in the heart at the ventricular level here. And now ask yourself, what do you think will happen if there is a hole between the right ventricle and the what? And the left ventricle? The point is, the kind of blood that reaches this what? This right ventricle, which type of blood is inside the right ventricle? That's a question. I believe you know it. But for those of us who've forgotten or new to this channel, the point is, right here, you have the inferior vena cava, right here, the superior vena cava, and they are both emptying deoxygenated blood. A blood that is deprived, a blood that is deprived or it lacks oxygen. There is no oxygen inside it, or very little amount of oxygen. So deoxygenated blood is getting into what? Is getting locked up into the what? Into this right ventricle. That is the type of blood that gets into what? Into the right ventricle. And normally, if you know the heart very well, the heart functions by pumping this deoxygenated blood through this pulmonary valve into the what? Pulmonary artery. And the point now is, why is it pumping it into the pulmonary artery? So the heart is pumping deoxygenated blood into the pulmonary artery to take it to the lungs, right here. So when it brings the what? The blood into the lungs, the blood is going to collect the oxygen from the lungs and bring it back into the what? Into the left atrium. That is the normal thing. Now, the point here is that there is pulmonary stenosis. A valve is here called the pulmonary valve. When it gets constricted and hard, blood will not be able to move out of what? Of the pulmonary, of the right ventricle again. So this gate has locked it up. Now the point is, a kind of prayer is going to be here. I don't want to be talking about prayer, forget about it. In short, this is the first one, ventricular with septal defect. We call it hole in the heart, right? Some kind of hole in the heart. The next thing is what? Pulmonary valve stenosis. And we said, pulmonary valve stenosis, what happens there is that there is a constriction of the what? Of the pulmonary valve. So blood is not going out of the what? Of the right ventricle, and it's not going to the lungs to take oxygen. Imagine that the blood is able to go to the what? Is able to go to the lungs to bring in oxygen. You know, there will not be reduction in oxygen, and there is nothing that is going to be triggering this to produce more erythropoietin, right? But the point is, this blood now, this deoxygenated blood, they are not even going to the lungs. And now the question is, where are they going to? Another thing we have here is overriding aorta, or overriding of the aorta. And what is happening there is just the presence or the attachment of the what? Of this aorta right here. Instead of it being attached to this left side of the heart, it is attached directly over this hole. And now, what do you think this is going to be causing? Firstly, if the oxygenated blood is here and they cannot go to their proper place, they are going to move easily into what? Into this what? Into this left ventricle. So the left ventricle is meant to contain oxygenated blood alone, but this deoxygenated blood will mix up with it, making it a mixed blood. And the oxygen level automatically is going to drop. So, which means it is still the same as saying the blood doesn't contain much oxygen. So, and all this what? Blood that has a low level of oxygen, because they both mix together, they keep on coming down as well, and they send impulse to the kidney and to the liver. And the liver is going to release what again? Erythropoietin. And that is going to trigger what? Hemocytoblasts to produce a new red blood cell. And the point is, they add more to the number of red blood cells, another 100, making 300. And that is doing what now? Increasing polycythemia, or causing polycythemia in short, which is the increase in the amount of what? Of red blood cells within the bloodstream. Guys, do you understand how TUF can cause what now? Can cause polycythemia. So, it can cause it mainly in two ways. The first one is just a single way, but with the contribution of the what? Of the tetralogy. The point is, the hole in the heart allows for deoxygenated blood to mix with oxygenated blood. hereby making it have a reduced level of oxygen. One. Apart from that, the aorta is overriding. So taking all this now down into the what? Into the bloodstream. And hypoxia is going to be detected by this guy. They will use erythropoietin, produce another red blood cell, thinking that the red blood cell is the issue, thinking that there are no vehicles to bring the oxygen into the bloodstream. However, we have a lot of them already. But the point is, there is nothing for them to carry. Now, apart from that, what do you think can cause polycythemia again? Now, let's assume that this person has a functioning lung, that the lung is okay, no COPD. So the lung is okay, no problem. The heart as well is perfect. Okay, the heart is okay as well. The point is, normally, a reduction in oxygen level now triggers the what? These two guys. So to do what? To produce erythropoietin. But the point is, we do not have a reduction in COPD, and nothing is mixing up with the normal blood to reduce the what? To reduce the concentration of oxygen. Now, what else can you think? Or what else can you suggest can cause polycythemia? Look at these guys. Kidney and the liver. They are the one responsible for releasing what? For releasing erythropoietin. Imagine that they are colonized or they are affected by cancer. And that's another condition here. Kidney cancer, or you say renal what? Renal cancer. And liver what now? Liver cancer. In cancer, what happens? There's always a what? Multiplication of what? Of cells. Now, let's assume that normally, inside the kidney, we have just a single cell. And it releases one erythropoietin. We have a single cell in the liver, and it releases one erythropoietin as well. Now, if they get colonized by cancer, mutation gets in, and they start duplicating seriously, and they become a lot. Tell me, how many EPO do you think they are going to be releasing? It's going to be high, like 10. This one releasing 10 too. Increase in the what? In the production of erythropoietin will cause a bombardment of impulse. Impulses are going to be what? If you have what? Increase in what? In EPO now. This increase will bombard the what? The hemocytoblast to produce what? Red blood cell. Increasing what? Polycythemia. Now imagine another one again still release it. We have another increase, another increase, another increase. So increase in erythropoietin will cause a bombardment of what? Of the hemocytoblast in the blood, in the bone marrow, with impulses of what? Of red blood cell production. And it will have no choice than to what? Than to accelerate the production of red blood cell and accelerate the movement of red blood cell into the what now? Into the bloodstream. Leading to a huge load. So busting what? Red blood cell into the bloodstreams. So another causes of what now? Of polycythemia. So we have COPD, we have tetralogy of Fallot, or you can just say, and what collective name can we give them? Because tetralogy of Fallot is not the only condition that affects the heart in such a way. You can just say cyanotic heart disease. Beautiful. Cyanotic heart disease or disorder. That one aside. So that is 2 now. So renal cancer and then liver cancer, making 4 causes. Now guys, let's assume that this person has a good kidney. The person has a good liver. Beautiful. The point is, what next? Let's assume now that these 2 guys are okay, and they send erythropoietin now. They release it to stimulate the what? The hemocytoblast. And imagine something is wrong with the hemocytoblast itself. Now, let me magnify what is really happening when erythropoietin, when it reacts with the hemocytoblast. Let me try to just magnify it a little bit so you can understand what is happening here better. You see, when erythropoietin now, let's try to magnify what is happening right here. So, let's bring it down. When EPO, erythropoietin, is coming to act on the what? To act on the hemocytoblast. Within the nucleus of the hemocytoblast, these dots that we have right here. So within that nucleus, let's magnify it a little bit. We have DNA. I'm sure you know that before. Now, on this DNA, we have several genes. Several what? Several genes. So, I have a lot of what? Lots of genes on this DNA. Now we're talking about genetic makeup now. Now you see, on this DNA of this hemocytoblast, we have some specific what? Some specific genes. Let's assume these guys here. And they're called JAK2. JAK2 gene. JAK what? JAK2 genes. when erythropoietin is coming, erythropoietin actually it binds with the receptor what? On the hemocytoblast to activate. To do what? To activate this JAK2. So when erythropoietin binds with the receptors on the what? On the hemocytoblast, what happens next is that these receptors they trigger or they activate JAK2 what? JAK2 genes. The JAK2 genes is now the one responsible for what? For knocking off the myeloid stem cell and the what? And the lymphoid stem cells. Myeloid and the what? And the lymphoid stem cells. Before they start producing things like what? Let's say collectively, start producing things like red blood cell, white blood cell, platelets. So the JAK2 gene are actually the what? The part of the DNA of the hemocytoblast that actually leads to the what? Production of all these guys, all these blood cells. Now imagine that something affects the gene and some kind of mutation occurs. Mutation means a change. So maybe some arrangements are not really good. We talked about oncology in the last semester, so you can check our video on that. Or if you have the manual, I mean the volume 1 of my MedSurg, so you can just check up to check types of mutation. So you understand all those things, point mutation, all this amplification and the likes. So forget about that for now. The point I'm trying to make here is that if there is a mutation here now, what? A mutation. A mutation strictly means change. If a change occurs, these JAK2 genes, they might not have to wait on erythropoietin again before they start doing their own work. It means these JAK2 genes, when they get mutated, they start producing what? They start producing all these cells themselves. So the point is, even without what now? Erythropoietin, this hemocytoblast is going to be triggering the production or stimulating the production of what? Of red blood cell itself. And when all these things happens, it leads to an increase in the amount of what? In the amount of red blood cells in the bloodstream. And we call that term polycythemia. As simple as that. I hope you understand. So, what next? Let's just come back one more time. You see, if the kidney and the liver are not causing an issue, they are releasing their own erythropoietin steadily at a normal rate, not so high. Or even they are not releasing it simply because they have no reason to release it. These hemocytoblasts, it has some kind of what? Some gene inside its DNA called the JAK2 what? JAK2 genes. Now the point is that these JAK2 genes, they are the one responsible for triggering the production of what? The division of what? Of these cells you are looking at here. So without JAK2 genes, erythropoiesis will not occur. Not even erythropoiesis alone. All the production of blood cells will not occur. Now, in cancer, these guys can actually get mutated. So when mutation sets in, they get affected and they start producing what? The blood cells themselves. Without what? Without any triggering factor. As simple as that. Now, let's now assume that the hemocytoblast is cool. Nothing is wrong with it. And the point is, it just gets produced, put the red blood cell at a normal amount into the bloodstream, which is our what? Our 100 red blood cell. You see, even if nothing is affecting all these processes, if nothing is affecting them, even within the bloodstream, polycythemia can still occur. And the question is, how? Right? Now listen attentively. If you have, let me look for a better place. Okay, let's use this side, guys. Let's say you have two cups right here. This is a cup. Inside this cup, you have 5 ml of water. 5 ml of what? 5 ml of water. And now, you put in 5 cubes of sugar. Good. 5 cubes of what? Of sugar. Now, what we are talking about here is concentration. Concentrate what? Concentration. Now, this is what? Sample A. Now, we have another cup right here for sample B. This guy contains 5 ml of water as well. 5 ml. However, it doesn't contain 5 cubes. We have just 2. 1, 2. That's our sample B. And what next, guys? We have the third cup right here. This third cup, it has just 1 ml of water. Just 1 ml. And then we have 5. 1, 2, 3, 4, 5. 5 cubes of sugar. That's our sample C. Now, here is my question to you guys. If you test this, it will give you a certain taste. Let's take this taste for A, normal. You know what? The normal taste that we want. If you test this B, this water, they stir it together, the cubes of sugar dissolved together with the water is from the solution. The point is, if you taste it, do you think the concentration of the sugar or the sweetness, do you think it will be higher than this or lower? You know the answer? It is going to be lower, which means concentration of sugar right here is what? Is low. But tell me, if you taste this C, what happens to the sweetness? What happens to the concentration of sugar? It is going to be high. Even higher than what? Higher than this. Now, the question you should ask yourself here is, why are we comparing these three guys with polycythemia? The reason is not far-fetched. See, I told you the bloodstream normally is made up of what? The bloodstream is made up of, guys, okay, I'll magnify when I'm editing. We said the blood normally, if this is a test tube now, we said the blood is made up of plasma, 55%. So you have a lot of plasma, something like 55%. And we have the red blood cell itself, or the other form the element order, 45%. 45%, this guy is 55%. Now, take this setting now as the normal, which means take this plasma as the what? As the fluid, and the red blood cell here, which is 45%, as the 5 cubes of sugar. That is normal in our body. Now the point is, imagine that we drained out this what? This plasma. This plasma is the same thing as this water. Instead of 5 mils, it is now 1 mil. And still, we have a lot of what? A lot of red blood cell. What do you think will happen to the concentration of red blood cell here? From normal that it is before, which is 55% to 45%. Since the plasma has been drained out, the point is there's going to be an increase in the concentration of red blood cell. And that is synonymous to the definition of what? Polycythemia. As simple as that, guys. Now, if you still do not understand, this is what I'm trying to say. You have a glass of water and you want to take just 5 spoons of gari. Now, if you pour the gari into the 5, if you pour the 5 spoons of gari now into the what? Into the glass of water, the point is the water will still contain it. It will not be too thick for you to drink. But imagine you drained out all the water. Just what? A low level of water, as in just like 1/3 of the cup. And you still pour 5 spoons of gari into it. What will happen to the solution we have? It is going to be very thick. Because the gari is going to swell. Oh, for those of us who doesn't know what gari is, cassava flour, to be precise. So the point is, it is going to swell up. And you will hardly find the fluid inside it again. Now tell me, if they ask you, which one has a higher level of concentration of gari between the one that has a whole glass of water and just 1/3? The answer is the 1/3. The point is that think of that gari as a red blood cell. You still have the normal 100 in the normal body, and it is being maintained by the plasma of 55%, which is the water, the glass of water. The point is, when you drain out that plasma, the concentration of the red blood cell increases. Simple. If you still find it difficult understanding this, tap me up privately. I'll try to explain as much as possible so you can understand. Now, what is the next thing? The point is, if red blood cell now, if they get into the bloodstream and they cannot swim very well inside the what? Inside the plasma. The plasma has reduced one way or the other. And the question you should ask yourself is, what drains out the plasma? Anything that can bring out water from your body can drain out the plasma. An example is something like vomiting and diarrhea. Vomiting and what? Diarrhea. But I want to add excessive. Beautiful. So, diaphoresis. Yeah. Excessive sweating. That is what diaphoresis means. So, using some kind of drugs like diuretics. Yeah. Diuretics. 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 So when you take diuretics, you urinate a lot. And when you urinate, the plasma level is going to drop, thereby increasing the concentration of red blood cell within the bloodstream, causing polycythemia as well. Now guys, not to stress ourselves, you see everything you've known right here. That is the etiology of what polycythemia. If they ask you to list the causes, you can start by telling them COPD, tetralogy of Fallot, or cyanotic heart diseases in general. So you can tell them what? Renal cancer, liver cancer making 4. So you have what? So mutation, so cancer making what now? Making 6. Excuse me, 1, 2, 3, 4, making 5 at this junction now. And after that, you keep going. So you're going to have what right here? You have things like what? Excessive vomiting, excessive diarrhea, plasma, diaphoresis, use of diuretics. Now the point is, I told you, once you understand all these things, you already know the types of polycythemia. Now, polycythemia is divided mainly into 2. Now, what 2 are those? So I'm going to draw a chart up ahead. Polycythemia can be grouped into 2. So the first one is called the relative polycythemia. Now the question is, what is relative polycythemia? Relative polycythemia is actually the ones that are dealing with what? Reduction in what? In plasma level. So whenever you have a reduction in what? In plasma level, and that reduction in plasma level leads to an increase in the concentration of RBC. That is what we call relative what? Relative polycythemia. Because you're actually defining polycythemia in relative to what? To the plasma levels. As simple as that. And you see, because it is not really a true polycythemia, we still have the same number of red blood cells, which is 100. Just that the fluid that drains out makes it appear as if they are too much in the bloodstream. You know what they used to call them? They used to call them pseudo polycythemia. Pseudo what? Pseudo polycythemia. Now, the word pseudo means false. As simple as that. Now, the question you should ask yourself is, if you have false polycythemia, is there something called a true polycythemia? You find out now. The point is, if we have relative polycythemia, the other one is called absolute. Absolute what? Polycythemia. And this absolute polycythemia is divided into 2 groups. The first one is called the primary polycythemia. Primary what? Polycythemia. And the second one is called the secondary polycythemia. Now, I will start from secondary. As a nurse or as a health worker generally, a doctor, so chill. The point is, when they say secondary to, they are telling you that that thing is what causes it. Now, if they say fracture secondary to RTA, it means this person has fracture secondary to caused by road traffic accident, RTA. So the point is, when they say secondary polycythemia, it means this polycythemia is as a result of a pre-existing disease or disorder. Now from here, can you actually highlight secondary polycythemia? Secondary polycythemia are those type of polycythemia caused by other disease conditions. Simple. Things like COPD. The person has COPD, reduces the oxygen in the lungs, and then causes tissue hypoxia, sending impulses to this guy, causing what? Increase in erythropoietin producing a lot of what? Red blood cells. So if someone has tetralogy of Fallot and develop polycythemia, that is what? It's secondary polycythemia. If someone has renal cancer, liver cancer, and the person later develops what? Polycythemia, it is a secondary what? Secondary polycythemia. So the diagnosis can just be polycythemia secondary to either of all these guys. I hope you understand what secondary polycythemia means now. What next? Talking about primary polycythemia. Primary polycythemia is also called polycythemia vera. And what vera means? True. That is the opposite of what? Pseudo. Which means what? False. So when they say polycythemia vera, it's actually the true polycythemia. And what is true polycythemia? True polycythemia is actually the increase in the amount of red blood cell caused by what? By this guy that we explained right here. The mutation of JAK2 genes. So the kind of polycythemia caused by what? The mutation of the JAK2 gene is the primary polycythemia. Or you call it the what? The polycythemia vera. It is the true polycythemia simply because it is the one that actually increases the what? The production of what? Red blood cell within the bloodstream, without having to do with a condition pre-existing, or without having to increase the what? Sorry, to reduce the what? The plasma level. As simple as that. Now, if someone has polycythemia, what can be the clinical manifestation? So, let's just quickly do that. Something like a pathophysiology. So, I'll be right back, guys. So, guys, just think of concluding right here without rubbing the board, simply because we are done with nearly everything. Apologies, please. Now, the point is talking about the signs and symptoms of polycythemia. The first thing you should ask yourself is rather, what will happen to the blood when the red blood cells are too much within the blood vessels? So if the red blood cells are too much within the what? If they are stocked up within the blood vessels, what happens is that there's going to be a thickness of the blood. And in anatomical terms, we call it increase in viscosity of the blood. Increase in what? In viscosity of the blood. So the blood is going to be too thick. And because it is very thick, their movement within the blood vessel is going to be very slow. And because of that, adequate blood won't be getting to where they're supposed to go as quickly as possible. And if oxygenated blood is not getting to things like the muscle tissue, it can cause fatigue. So fatigue is a clinical manifestation. So, not only that, another thing is there is going to be difficulty in moving the blood through the what? Through the cerebral arteries to supply the what? Supply the brain. Because of that, things like dizziness, headache can set in. So not only that, another thing is that with the fact that there is a viscosity, there's an increase in the viscosity of the blood is thick and it's moving slowly within the blood vessel, it can increase the what? The chances of clotting, and the person can have thrombosis. Thrombosis. So clotting will be occurring within the vessels. And when clots occurs, you know what that can cause later. It can occlude different arteries in the body, preventing supply of oxygen to what? To those organs. Now, if there's an occlusion to the what? To the blood vessels supplying the brain, you know what that will cause? Things like stroke. So, that's a complication actually. So the point is, what polycythemia will cause is actually a reduction in the what? In the movement of what? Of red blood cell. And due to the what? Due to the increase in its viscosity, the blood gets thick. And then it causes fatigue, dizziness, headache, blood clotting, as simple as that, and so on and so forth actually. So that is just the end for polycythemia. So in our next class, we are going to be talking about the white blood cells. And after that, we go straight up to leukemia. So before the ending of the week, we should be done with leukemia as well. And next week, I'm thinking we should go to research. So God spare our life. So in some other time, guys, I wish you the very best.